This conference will now be recorded.
Good morning, everybody. Thank you for joining us on this bright and sunny, beautiful day today. I just want to thank you again for joining us as we introduce the Lurie Children's Division of Orthopedic Surgery and Sports Medicine teams. For this session, we are introducing you to Dr. Niraj Patel, as he will be discussing the pediatric ACL. But before we get into Dr. Patel, I would like to talk to you about our Division of Orthopedic Surgery and Sports Medicine that is nationally ranked by the U.S. News and World Report. We care for more than 30,000 children each year. We provide a range of services for children with bone, joint, muscle, ligament, tendon, and nerve disorders, and offer the only pediatric bone health program in Illinois. These are some of the reasons why we are able to recruit some of the finest specialists like Dr. Patel. The Knee Injury Prevention Program, known as KIP, is a neuromuscular training program designed to reduce the risk of ACL injuries among female adolescent athletes. The KIP for Coaches is a free online training program to help coaches reduce the risk of ACL tears and other lower extremity injuries in their athletes from ages 10 to 21. In KIP training, coaches learn how to lead their athletes through a 10-minute warm-up routine that includes strength training exercises, plyometrics, balance training, agility drills, and active stretching. Now, as a coach, I could tell you, I don't sit there and do those exercises because I'm not going to be doing plyometrics. But good thing they're between 10 and 21 years old. They got a lot of energy. Then before we get into Dr. Patel, I would like to remind you that our new Skokie site is up and running. We have over 20 specialties, including orthopedic surgery, sports medicine, and CAS care services. Our sports medicine team is there 5 days a week, one of which is Dr. Patel. Dr. Niraj Patel is an attending surgeon and assistant professor of orthopedic surgery at Northwestern University of Feinberg School of Medicine. He completed residency training at New York University Hospital of Joint Diseases, followed by a fellowship in pediatric orthopedic surgery at the Children's Hospital of Philadelphia, where he acquired advanced techniques in pediatric sports medicine and fracture surgery. His clinical interests include ACL injuries in all ages, cartilage injuries, patellar instability, and pediatric fractures. In addition to his medical training, Dr. Patel also holds master's degrees in public health and biomedical science. Given this background, he is an active researcher with numerous frequently cited publications and a strong presence at national and international meetings. He has served on the diversity committee of the Pediatric Research in Sports Medicine Society and the evidence-based practice committee of the Pediatric Orthopedic Society of North America. Dr. Patel is one of the 10 members of the American Academy of Orthopedic Surgeons work group tasked with creating clinical practice guidelines for the management of ACL injuries. He was also awarded the St. Giles Young Investigator Award by POSNA for a randomized controlled trial of ACL in all reconstruction in the pediatric population. But that's enough for me. Let's get you over to Dr. Patel, where he's going to go tell you about his journey here to Lurie Children's and discuss with you the pediatric ACL. Dr. Patel, I'll let you take the screen over.
Thanks, Chad. Appreciate it. Good morning, everyone. Let me share my screen. And there we go. Okay. Well, thanks everyone for joining. I know it's a little early, so appreciate you spending the start of your day with me. I will give you a brief talk. This is a condensed version of a longer talk I often give on pediatric ACL injuries, which are definitely a primary interest of mine, and not to be too melodramatic with the title of this talk, but kind of an issue in our current society with active athletic kids. So, as Chad mentioned, I am Neeraj Patel. I'm one of the orthopedic surgeons here at Lurie. He gave you the clinic locations I go to. I have previously been confused for a young Charles Barkley or these guys from the movies, but I am not them. I'm originally from the great state of New Jersey, specifically Edison, New Jersey, home of the first light bulb. I trained at NYU Hospital of Joint Diseases in orthopedic surgery for my residency, as Chad mentioned, followed by a fellowship in Peds Ortho at CHOP. And then I made the long migration over to Chicago, where I've been at Lurie since 2018, since finishing my training. So it's been great here in Chicago. As Chad mentioned, I'm down at Lincoln Park, Westchester, Skokie, and New Lenox, so kind of everywhere, and happy to take care of the kids that need care all over the Chicagoland area. So getting to the ACL, as you all know, if you think back to anatomy in school, the anterior cruciate ligament is in the center of the knee, so in the intercondylar notch. It attaches to the lateral wall of the intercondylar notch on the femur and in the front of the tibia, and it provides rotational and anterior stability to the knee. This graph here is from a study in New York State showing the rapidly rising rate of ACL reconstructions in the pediatric population. So in kids younger than 18, you can see between 1990 and 2009, the rate of ACL reconstructions really skyrocketed. And so there are a lot of reasons we think that contributed to this. One is that there's definitely a trend towards a higher intensity of sports at a younger and younger age, which results in more potential exposures or essentially opportunities for injury. There's also more girls playing sports now than there were 30, 40, 50 years ago. And research has found that girls may be at higher risk for ACL injuries for a number of reasons than boys, and so that may be leading to this increasing incidence. There are certain neuromuscular factors that contribute to this. So just things about, kind of dynamic movements and control over the knee with jumping and landing and these kind of things. And anatomic factors as well, which are harder to control because these are things kids are sort of born with. So, standing alignment, physiologic laxity, generalized ligamentous laxity, all these kind of things. So that results in this high rate of ACL injury in kids, and that just seems to be growing and growing, unfortunately. So some sports are more at risk than others. This is a systematic review that we just completed last year, sort of up to date, and it shows that females, who are the lighter shaded bars to the right, soccer is by far the sort of #1 offender for both girls and boys sports. Girls soccer is the #1, followed by gymnastics, although the caveat here was there's only one paper in the systematic review on gymnastics, but lacrosse and basketball are also high risk in girls. And then in boys, really football, lacrosse, and then soccer are the high risk sports. So what is the history here? So normally when these kids get injured, they have a pop in their knee with some pain and swelling. It can often be a non-contact injury. So don't be fooled by the kid that shows up in your clinic or in your office or in the emergency room or whatever, who says, I was just running down the field at practice and then I turned to change direction to cut or something, and oh man, my knee it popped and it was killing me. That absolutely can be an ACL injury. It doesn't need to be, getting tackled and some violent mechanism like that. So just things to keep on your radar. They will often complain of instability, again, because that ACL provides rotational and anterior stability. They may have difficulty with the range of motion early on because of the pain and swelling, and also because they may have concomitant injuries like meniscus tears or cartilage injuries that may limit motion, especially early on. So the big question is often, when do we refer? When do we get an MRI? What do we do? So as primary care docs, physical therapists, that kind of thing, that's often one of the big things. So I think, just quick in a nutshell, I'd say any child that has this kind of history that we just sort of briefly mentioned, there's a pop in the knee followed by pain and swelling. And I mean, a good amount of swelling. I ask kids, if I was standing across the room and you were wearing shorts, would I be able to see like, wow, that's a really swollen knee? A big joint diffusion. So kids that have that kind of story with some of these complaints, I think those are always pretty reasonable grounds for either getting an MRI and or referring them to an orthopedist or a sports doc. As you'll see, if you delay diagnosis and things like that, the kids tend to have worse outcomes. So these are things, while they're not emergencies, you don't want to miss. On exam, they'll have an effusion oftentimes. They may have some tenderness, especially at the joint line. If they have a meniscus tear, the joint line tenderness is sensitive for meniscus tears. Then we'll do our stability maneuver, so anterior drawer, lockman, pivot shift, which you may remember from school, even if we don't do them often anymore. So this is the lockman test on a child that's asleep for surgery, and you can see it's very loose and unstable anteriorly. This is the pivot shift test, which is definitely more tricky to get on a awake child that's guarding or a little scared, but you can see a little bit of a pop as you bring the knee up. All right, so that's the lockman, or the pivot shift test, shows rotational instability. The first step in workup is usually plain x-rays, so we do that largely to rule out other things. So on the right-hand side there, that's a lateral x-ray of the knee in a kid with open growth plates, and you see a tibial spine fracture, which is sort of a skeletally immature or young pediatric equivalent of an ACL injury in some ways, where the ACL basically pulls off a piece of the bone rather than rupturing the ligament itself. So you want to rule that out, especially in the young kids. But you may also see what you see on the left there, which is a Sagan fracture on the anterolateral part of the tibia there. And we think that when you see that on an x-ray, it's actually pathognomonic for an ACL tear. So if you see that, there's a very, very high chance the kid has an ACL tear. So we get these x-rays first to rule out other things and get some more clues as to what might be going on. And then after that, typically MRI is the confirming test of choice. We see here that on the sagittal MRI on the left that the ACL is torn, where the PCL in the back of the knee is still intact. So that black thick ligament is what the ACL should be looking like, and it's just not there. So as we get into treatment, I'd be remiss if I didn't talk about the idea of prevention, because this is very important, right? So we always say an ounce of prevention is worth a pound of cure, and that's true in ACL injuries as well. So I know Chad put in a plug for our KIP program. So Dr. Labella at Lurie, Dr. Cynthia Labella, has really pioneered and rolled out this knee injury prevention program for girls primarily, but I think it does work, and it is beneficial for girls and boys alike in all sports. So first of all, prevention programs do work. These are neuromuscular training programs that work on, jumping, landing mechanics, neuromuscular control of the knee, that kind of thing. And not just the KIP program, but other similar programs have found a lower risk of ACL tear in patients that undergo this kind of training. And the number needed to treat is 109. So for every 109 patients that go through this program, you prevent one ACL injury, which is actually quite effective. So I would again put in a plug for this. And if you have patients that are athletes, young, adolescent, that kind of thing, this is something that is probably worthwhile for a lot of those folks, especially if they participate in those higher risk sports that I put up on that earlier slide. The other thing I will add, there's seemingly a little more conversation these days about various disparities in medicine. And a decent chunk of my work has been looking at some of these things in pediatric sports medicine. This is a paper we wrote a couple of years back, looking at differences by race and insurance status in kids with ACL tears. And you see that Black and Hispanic kids had longer delays to the operating room, so almost on average, 26 days longer. And publicly insured children, kids with Medicaid, also had a longer wait till surgery than kids with private insurance. And the result of that is you see that last row down there is the percentage of kids that had a meniscectomy. So anytime you resect the part of the meniscus, that means that you had an irreparable meniscus tear, and that's not great because that puts you at risk for arthritis. So there were racial differences as far as that goes as well, and that's largely because of the delay in surgery. So I think it's important to be aware that there are certain populations out there that tend to be kind of I wouldn't say neglected, but get sort of differences in care, and may get delayed diagnoses and treatment and so forth, and then are at risk for worse outcomes. So especially in those populations, you want to have a high level of suspicion and really do what it takes to make sure they get their MRI, they get referred, whatever it is, in a timely fashion, so we take care of them. And similarly here, if you look at the number of physical therapy sessions after surgery, there are, again, insurance and racial disparities in the number of physical therapy sessions that these kids got after, which again is a very, very important factor in terms of predicting their outcomes afterwards. As far as the surgery goes, I won't go into the nitty gritty, but there's a lot of different ways to do this, many ways to skin a cat, as I always say. the pictures on the left, so pictures A, B, and C, are techniques that we've developed over the last 15 or so years to do ACL reconstruction in kids with open growth plates. So 20 years ago, those things didn't even exist. And if you were, 8 years old or something, tore your ACL, you would have to either wait till you were done growing, so 14, 15, 16, to have surgery, which was a really long, difficult wait, or you never had surgery at all, and then you ended up with other bad knee pathology. So now we have these other techniques. So now the question is not, should we do surgery on these really young kids if they need it, but what kind of surgery do we do? And you don't have to get lost in the weeds on these images here, but this basically just shows that there's these 5 different sort of techniques that are useful for different age groups. But the question is, what are the sort of strict age cutoffs at which we use these different techniques? And this is a survey of 101, I believe, pediatric sports surgeons. And you can see there's some disagreements at certain transitional age groups in terms of what technique. So now the next question is kind of what technique is best for which age, and we're in the process of trying to figure some of that out. In terms of graft, so we usually use the patient's own tissue to reconstruct the ACL. We found that allograft or donor graft in young active patients fails more often. So you could use a patellar tendon, hamstrings tendon, quadriceps tendon is something we do a lot. It's a sort of more recently popularized. And then the other thing I'll really quickly add in is, I don't know if you guys caught this several years back, but a bunch of Belgian scientists apparently discovered a new ligament in the knee. I'm sure, someone didn't just put it there 8 years ago, but this is something that they discovered, and it's called the Anterolateral Ligament. This is, the thinking is it provides some additional rotational stability to the knee, secondary function to the ACL. And so now we're reconstructing that ALL with the ACL in some kids, in some patients, those that we think might be at higher risk for failure after surgery. So this is just a study, a prospective cohort study that showed that adding that ALL reconstruction with a hamstrings allograft ACL resulted in far less ACL graft failure in follow-up and a better return to sports. And this is a randomized controlled trial comparing an ACL with a similar ALL reconstruction technique called modified Lemaire to just an ACL alone. And again, in this high-risk population, the rate of graft rupture and failure is much, much less if you added this extra little reconstruction with your ACL. So that's something that we're working on at Lurie too. As far as return to sports, we usually wait 9 months. And we have the physical therapist do a battery of functional tests, some of which are listed here. So we try to make sure they're safe and as strong as possible before they go back. And real quick, the title of this talk were the kids weren't all right. And so I know we're kind of running a little short on time here, but I'll zip through this. And the reason I entitled that is there's a lot of stuff I at least kind of lose sleep over and worry about after surgery for these kids. This is the first thing that we worry about post-operatively is stiffness. So this is a study from Boston Children's several years back. One of our other docs, Craig Finlayson, is on this from when he was a fellow there. This is a large study of 933 knees, and they found risk factors for stiffness after ACL reconstruction are the ones listed here. So females, slightly older kids, if you had meniscus repair, and then bone patellar tendon bone graft or patellar tendon graft was another risk. We kind of sort of just redid that study because now, like I mentioned, quadriceps ACL is becoming more popular, and we do a lot of it at Lurie. So we wanted to figure out what is the rate of stiffness with quad ACLs. So we found it to be 6.3%, which is slightly more than hamstrings, but less than the patellar tendon, so that's promising. And then these are the other risk factors that we found here. The other risk is contralateral ACL injury. So believe it or not, when you tear one ACL, you're at higher risk of tearing the other ACL at some point. So this is a study we did a couple of years back, almost 500 kids with at least 2 years of follow-up and a mean of 4.5 years of follow-up about. We found that the graft failure rates of re-tearing the same ACL was 12%, and the contralateral or the opposite side knee injury rate was 7%. So relatively high, especially if you compare it to adults, where large database, or excuse me, registry, national registry studies show the rates of ipsilateral graft failure and contralateral ACL tear to be sort of 3 to 4%, right? So you compare these numbers, and they're much higher in kids. And if you add those up, 19% of these kids will come back with an ACL injury in either knee. So that's, almost 1 out of every 5. And some studies even have higher rates than that. So if you think about it, if you tear your ACL, you're at a 1 in 5 risk of coming back with another ACL injury if you're a young active athlete. And then looking at return to sports, again, this is one of these studies that found an even higher rate of graft failure and contralateral ACL tear. But They also, to me, the big take-home point of this study was that each month of earlier return to sport resulted in a higher risk of re-injury. So that's the reason that I wait at least 9 months, sort of blanket statement for everybody, and then potentially even longer if they're having trouble meeting, passing those functional tests that we talked about or having any other issues. So, the biggest thing I tell the kids that this is a two-part story. So part one is the surgery, and we do our best to do a great job, do a great surgery, put everything in the right place and make it good. But really part two is the physical therapy, and it's 9 months of it. Because these kids aren't professional athletes, it's not like every day, twice a day, they have a trainer and a therapist and everything working with them. So they go to therapy a couple times a week, but then it's really on them to do their exercises at home with their parents and stuff like that. So I'd encourage you, if you guys have patients who have had an ACL injury and are in rehab and all that, just kind of check in with them, see how that's going, and encourage them to do their homework as far as their therapy goes, because it's very, very important and it makes all the difference. So just in summary here, like Chad mentioned, I'm very, very interested in many different research endeavors, the biggest of which is in the ACL. So we've got retrospective studies on the quadriceps ACL that we are in the process of publishing, and we've presented at some meetings. We have a prospective quadriceps ACL registry in partnership with a colleague from the Children's Hospital of Colorado. We are looking at the anterolateral ligament in a lot of different ways. We're doing an MRI study with our radiology colleagues, and then we are just about ready to start a randomized controlled trial at Lurie that I'm leading in partnership with other investigators at CHOP, Texas Children's, UCSF, where we will be randomizing children to either get an ALL reconstruction with their ACL or not, and then compare their outcomes down the line. So a lot of exciting stuff happening. Hopefully this will help us answer some of these questions and make things better for these kids as we move forward. So this is my email address. I know Chad had some more contact info for me and my team on the other slides before. So by all means, I'm happy to talk to anybody. If anyone needs anything down the line, please feel free to reach out. I'm happy to help however I can.
Dr. Patel, that was fantastic. Thank you so much. I learned a lot, and I'm sure everyone else here did too. And questions are coming in the chat room. So I'm just going to go right into it. And if anybody else has questions, feel free to type them in, and I'll read them off to Dr. Patel for you. But one of the things, one of the questions that have come in, and I've been hearing a lot about, is many kids have been off of sports for about a year now, Dr. Patel, and now they're getting back into it. Do we have heightened concerns of injuries going back into it? Should kids take it slower? What are some of your suggestions? Should we be worried about higher risk of injury with kids? Maybe deconditioned due to less activity during COVID? What are your thoughts on that?
Yeah, that's a great question. And I think, that's a lot of what we've been sort of chatting about behind the scenes in our ped sports world. There's a lot of whispers about that kind of thing, and we're all curious to see when things really fully open back up and kids are really back at it, if there's a spike in injuries and that kind of thing. And not just ACLs, that other types of injuries, and major and minor alike. So I wouldn't be surprised, unfortunately, if there is a little bit of that spike. And the best way to sort of prevent that, like you mentioned, is to go back to sports gradually. So if you haven't been doing anything for a full year, you don't want to go from 0 to 100 miles an hour right away. I think that's sort of good advice in general in life, but especially, coming out of this pandemic. And then, things like the KIP program, again, not to keep putting in the plug for it, but things like that are really good as well, because it kind of just makes sure that your knee knows how it's supposed to be acting and how it's supposed to be working, and hopefully lowers that risk of re-injury. So yes, I think go back gradually, and then, a little bit of that neuromuscular training, in one form or another is probably helpful.
That's great. Yeah, I could tell you firsthand, the KIP program is an outstanding program. We use it here where I live in Arlington Heights, and many of the coaches have used it before me. So I know it's appreciated here. One of the questions came in is if there is a long delay in surgery and care, and if a kid does need some surgery, how much earlier have you seen arthritis begin? Also, for those kids treated early, are they predisposed to arthritis later in life?
Yeah, so that's a good question too. So the thing with ACLs is that all those kids, regardless of when they're treated or even how they're treated to some degree, are at risk for arthritis later in life. And that's just, unfortunately, secondary to the injury itself. So once that injury happens, that alone puts them at risk, regardless of when or how they're treated. I would say overall, we don't have a lot of great compelling data that shows that the later you're treated, the higher risk, or the timing by which you're treated affects your risks of arthritis. It's more the other outcomes. So things like residual instability of the knee, or we do know that the more chronic ACL injuries that have delayed diagnosis, delayed treatment, have worse irreparable meniscus and cartilage injuries. And so you could theoretically say, well, if 1 + 1 = 2, then if you have bad cartilage or meniscus injuries that you can't repair, then those things put you at higher risk for arthritis than a lack of those kind of injuries. We don't have the data that kind of bears that out definitively, but we do know that you end up with worse injuries inside that joint, and potentially things like residual laxity of the knee. Even after a good ACL reconstruction, the knee is still a little loose. The return to sport rate is not as good, and overall kind of patient satisfaction isn't as good as well. So arthritis is one thing, certainly long-term, that we look at, and that's not something that happens in like 2 or 3 years. That's more like in adulthood. But short-term, there's also a lot of other things if the care is delayed.
Okay. Well, thank you for that. Back to the prevention. One of the things I've always wondered is in preventing injury is the field type or the type of shoe you wear, or things like that. Does that help prevent or cause injury? For years we saw different field turfs and stuff like that where kids are starting to play on more now. Do you feel that the field turf has been progressing as far as safety goes compared to, like, let's say, natural turf?
Yeah, that's a good question. I mean, I know traditionally, we talk about turf often being at higher risk of injury. So, in an ideal world, yeah, just having regular grass everywhere would be nice. But I think, in this population, there's a lot of other factors beyond just unfortunately, beyond the playing surface, I think that are probably a bigger deal as far as risk of injury. And, not to sort of ignore your question by any means, but we look at like early single sport specialization, things like that are heavily studied and heavily talked about right now in our line of work as things that put kids at risk for both acute injuries like ACLs, but also chronic and overuse injuries. So I think, while playing field may have an impact, and I think, shouldn't be ignored completely, I think there's other factors that are more important in kind of the risk of injury, and this sort of trend or pattern towards early single sport specialization in young kids is one of the things that's a little bit problematic.
Yeah, it sure is. You just brought up make possible rehab earlier, and Tom Dyke just brought in a question, and this is what he said: would biasing the contralateral lower extremity during rehab, such as unilateral strengthening and balance training, at a higher demand than the post-operative ACL decrease the risk of having a contralateral injury? Should this be a priority in rehab?
Yeah, that's a great point. So Tom, thank you for bringing that up. I mean, even with the functional testing that we do, we say, well, we think that the contralateral uninjured knee is sort of the gold standard normal that we compare the progress of your injured knee to. But really, studies have found that your contralateral knee, for whatever reason, kind of goes to sleep a little bit too over the course of that 9 months or whatever it is. And so are we kind of almost comparing two flat tires? So in our ACL rehab protocol that both Dr. Finlayson and I use, we have a standardized protocol at Lurie. We do ask to start looking at the other leg at some point down the line during the rehab course, and strengthening that, working on neuromuscular things for that. We do implement the KIP program itself actually as part of the protocol, as part of a prevention mechanism to try to prevent contralateral injury. So yes, I think the short answer is for sure the contralateral limb should not be ignored post-operatively because of that high risk of contralateral ACL injury. And we know that the opposite leg does sort of doze off and get weaker or whatever you want to call it after surgery as well.
Thank you. Tom, thank you for putting that question in. Actually, thank you for joining us today. This is great having you. And so many of you here with us today. I know we're getting tight here on time. We're just about to close out the session. So if any, oh, looks like we have another question in from Deanna Phalen. What's your opinion on prehab? Do you tend to prescribe or do you prefer to hold off until after surgery?
Yeah, thanks for asking. And I gave this talk actually to a bigger version of this talk to a bunch of physical therapists previously, and I told them I meant to add a slide on that. So thanks for reminding me again. So yes, prehab is often very important. And for everyone else, that just basically means before surgery, sending them for some rehab. So I think we often do that, not always, because some of these kids, I see them, kids with Medicaid, like we said, often delayed diagnoses, delayed referrals. So I see them 3-4 months after their injury. And by then their strength is back, their motion is back, and we're just like, we just need to get to surgery at this point. But yes, otherwise we will often send them to therapy before surgery to work on motion and some quad strengthening and things like that to really get them teed up. So that is a very important part of the overall treatment process, I would say. So yes, thank you for bringing that up.
That's great to know. Yes, thank you for asking that question, Deanna. I think we're just about to close out here. So if anybody else has questions, feel free to type them in the chat room. I'll send them over to Dr. Patel, and we can send them back over to you later. Or if you like a personal visit or a virtual meeting one-on-one with Dr. Patel, we could schedule that later on in the spring or the summertime, and we'd happy to introduce you all to Dr. Patel. But we are going to close up here, and I just want to thank everybody for joining us today. Dr. Patel does see patients in our Lincoln Park and New Lenox and our Westchester office, and of course, as we mentioned earlier, in our new Skokie facility. Dr. Patel's phone numbers are right here on the left on the screen. You could reach him on his office at 312-227-6190. He has a direct line of 312-227-4485. And Dr. Patel was kind enough to provide his cell phone number for instant contact at 908-472-5374. Email at neepatel@luriechildrens.org. And of course, for those of you who have it available, Rapid Connect and Epic in basket message. So this is being recorded, as most of you know. It'll be sent out to you all after the session, and I would encourage you to share this with your colleagues. But on that note, Dr. Patel, thank you so much for joining us today.
I appreciate it. Thanks, Chad, for setting this up, and thanks for everyone who chose to start their day with us. Hope it was worthwhile. And like I said, please feel free to reach out if you need anything at all.
All right. Thank you so much. Enjoy this beautiful day, everybody. Be well. And we'll see you at our 10:30 session. Thank you so much. Bye-bye.
Thank you.